Good morning, everyone, and welcome to today's webinar hosted by PYA. Today, we are continuing our PYA Perspective series with a presentation on physician recruitment arrangements on paper and in practice. PYA is happy to present today's webinar in conjunction with Hooper, Lundy Bookman, PC. Before we get started with the webinar, I'd like to go over a few housekeeping items. As this event is for CPE credit, there are some additional steps we will take in order to comply with NASBA requests. In accordance with NASBA, attendees will be provided 3 polling questions throughout today's webinar. Responses are documented electronically. Attendees must respond to these polling questions within the allotted time in order to receive CPE credit for this course. A post-event survey will also be provided for attendees to submit regarding their webinar experience. The polling questions and post-event survey must be submitted for proof of participation today. You will have the opportunity to submit questions to today's presenters by typing a message into the question pane of the control panel. We'll collect these and address them by email after the webinar. All of our webinars are recorded and released with a copy of the slides after the event. With that, I would like to introduce Tynan Kugler, Principal at PYA, Amy Joseph and Charles Oppenheim, Principals at Hooper, Lundy Bookman, PC.
Thank you, Laura. We're excited to be able to speak with you all today about physician recruitment arrangements. We're going to, since there are 3 of us, keep it very conversational as we go throughout and look forward to working through several of the regulatory compliance and other issues that we all come up with in our practices specific to those agreements. So as Laura said, I'm Tynan Kugler. I'm with PYA, and I'm joined by Charles and Amy, and would love for them to just give a brief overview of themselves and their firm, and then we'll kick it off.
Thanks, Tynan. This is Charles Oppenheim. My partner Amy Joseph and I are with Hooper, Lundy Bookman, which is the largest law firm in the country dedicated exclusively to representing healthcare providers. We're coast to coast. And Amy and I are also co-authors of the American Health Lawyers Association's book on the Stark Law. So we bring that to the table as well. Thanks very much for joining us today, and thanks for having us, Tynan.
You all are welcome, and glad we've got the Stark Law experts, because this is certainly one of the areas that comes into play, key area for recruitment arrangements. So just to talk through what our agenda for today is, we'll talk through some current trends and tee up some pitfalls that we see in our practices. Charles and Amy will talk through the regulatory and compliance implications. I will talk through some of the challenges and approach to provider needs assessment. We'll call them sort of the modernized provider needs assessment, and those are done both for compliance and for strategic planning reasons. And then we'll end with some conversation about how you maximize an effective physician recruitment arrangement and tie all of those pieces together. One of the things we did want to make sure we let everybody know is we're not going to specifically address some of the nuances related to advanced practice providers, but don't forget them, because there are some nuances related to recruitment of APPs, and we couldn't help ourselves but to mention that here. So with that, let's talk about some of the current trends. No surprise here, but as everybody can imagine, COVID really has fueled some of the recruitment activities. There are a number of different organizations that you all may be familiar with that report and cite statistics on recruitment and growth and recruitment trends. And one of the interesting ones was how the recruitment trends have changed from 2020 to 2021, respective to various parts of the healthcare system. And today it's interesting that what we're talking about, because in doing some research for this, the biggest jump from 20 2020 to 21 has been in the hospital recruitment space. Medical group recruitment stayed about the same, and some jump in academic medical center recruitment too. So what that tells us is what we're talking about today is especially timely. Again, probably no surprise, but top recruited specialties, and I think Charles, Amy, you're probably seeing the same thing as we are, but primary care, family medicine, and OBGYN are two that are particularly cited on the primary care side, and a myriad of different specialties, but I think we're hearing neurology, orthopedic surgery, gastro, cardiology. Those are the ones that seem to be coming up more readily these days and within maybe the last year. So on the next slide, let's talk a little bit about those shortages, because again, we've all heard about shortages, but some of the numbers are really rather astounding. And these come from a variety of different sources, but just to give some context, one source, which was MD Thrive, who also had some of the statistics on the prior slide, they say that by 2030, there's going to be a shortage of physicians. The shortage is going to reach more than 120,000, with about 55,000 of those being in primary care and the remainder being in specialties. And there are a number of reasons for that. Aging population. Some other really interesting statistics is that in 2020, the 65 and over population was about 54 million. That's expected to grow to 80 million by 2040, which is really not that far away. The 85 and over population will have quadrupled between 2000 and 2040. So, lots, again, no surprise, but the magnitude of those numbers, I think, brings it back home. Overall population growth, another one, large number of physicians nearing retirement age. We'll talk about that in a minute, but when we talk about provider needs assessments, but the AAMC basically says that in the next decade, 2 out of 5 physicians will be over the age of 65. So planning has to start now. Health status of the population, and then the geographic, we'll call it maldistribution, but just distribution of physicians, with primary care shortages going to continue, fewer physicians wanting to go into primary care, and then rural areas are still struggling to attract physicians to rural areas. And then finally, one of the things that, again, we're not going to focus on APPs, but it's important to note that they're playing a more prominent role when we think about providers and the complement of providers. So high level, we're going to tee this up and then we'll go into some more detail, but just some of the pitfalls that we see in our practice. And Charles, Amy, jump in here, because this will, I know, set the stage for some of what we'll talk about at the end. Is, we'll say the provision of support in a recruitment agreement that's more than reasonably necessary. So as you can imagine, the key there is what's reasonably necessary, and we can talk through some of that from our various perspectives. Excluding, so when you're developing a recruitment package, not considering income from other sources as you're thinking about that support amount and what you're calculating for that support.
Sorry, Tynan. One point I want to jump in and make sure everybody's real clear on right at the get-go is when we're talking about physician recruitment here, we're talking about traditional assistance provided to support a physician being recruited into private practice in the community, as opposed to a hospital recruiting a physician to become an employee of the hospital or the hospital's medical group affiliate. So I want to make sure that everybody understands that's what we're talking about here, is we're supporting the recruitment into the community. Sorry, go ahead, Tynan.
No, that's a great qualifier, because I think one of the things is, we're seeing hospitals and health systems use sort of a myriad of different affiliation strategies. And one of the ones that I think we're seeing more of, which again is why we're doing this presentation, is that income support to a private practice, that's just is becoming part of and more prominent as one of those strategies. So Physician practice guarantee of the repayment. So essentially there, what we mean is where, physician practices in some way, shape, or form are essentially shielding the liability that the physician may have. And Charles and Amy, I know, can talk contractually about how they see those typically structured. It's not just the identification of the support that's reasonably necessary, but it's the tracking of those expenses. So it's the tracking, the auditing, and making sure that we're all holding true to what the parties have contractually agreed to. And then sort of the place where I reside mainly is in, do you have an identified or supportable community need? And we'll talk through what we mean and some of the trends we're seeing there. So before I move to the polling question, Charles, Amy, anything you want to add there?
Well, I think, to help put things in perspective for me, when we think about the myriad of options, the tools in the toolbox for hospitals to try and meet community need, when we think about these pitfalls and how they really are specific to recruitment arrangements, because other tools might be direct employment or independent contractor arrangements or direct employment through a hospital or hospital affiliate. And then it's a different discussion. We're talking about what's fair market value, and we'll talk about that more coming from other slides, but you'll see that's not here. We're focusing on what's reasonably necessary as one example. So it is a different analysis and assessment, and that's just a word of caution as we go through, because sometimes when I work with clients, it gets a little bit blurry, right? Sometimes the discussion gets a little blurry across these different tools, and recruitment arrangements are really a different animal, because we are talking about recruitment assistance out into the community to a private practice that is a referral source.
Yep.
So a couple things. So one is, Amy, you might want to move closer to your microphone because you're a little echoey. Also, in terms of community need, traditionally, and this is where Tynan's going to talk quite a bit, when hospitals do physician recruitment and support the recruitment of physician of a certain specialty into the community, they're typically wanting to demonstrate that there is a bona fide need in the community for that type of a physician. And the IRS, for example, has talked about the fact, and this is for tax-exempt hospitals, that you should be focused on the community's need, not just the specific needs of the hospital. The one exception that the IRS has recognized is, recruiting radiology, because the hospital needs radiology coverage in order to stay open. And by extension, many of us have interpreted that as permitting recruitment, even without the community's need for it, if the hospital itself has a need for a doctor of a certain type in order to basically deliver services that it's providing into the community. So that's kind of the community versus hospital need is something we're going to talk a little bit about as we go.
Yep. Okay, I think we're ready for our first polling question.
Thank you. The first polling question is, how would you describe your organization's level of sophistication with physician recruitment arrangements? Mature with a significant number of physicians supported, established but still growing, in its infancy, or what physician recruitment arrangements? Remember, you must fill out the polling question in order to receive CPE credit. You will have 30 seconds to answer. Thank you for participating in our poll. Now I'll hand it back over to Amy.
All right, thanks so much. I'm just taking in the results of the poll as well, which are interesting.
It looks like a large portion of the audience is pretty deeply into this area. So we have a sophisticated group.
Yeah, that's great. That makes it fun for us, right? We can get into some complicated and nuanced topics. But before we do that, to make sure we're setting the stage, we want to talk through a regulatory overview of what are the rules here and compliance considerations We're mostly going to do that from a legal perspective, but I want to invite Tynan to just interrupt, weigh in with anything that you want to add as well, because we work so closely together, between consultants and firms on these types of issues. So as you heard, in the first few slides, recruitment arrangements, they really can offer significant benefits. I expect that's why many of you have joined today, because you see the value in these. They can really help support a hospital mission to serve the community. They can plug gaps in needed specialties, but at the same time, they really can be a minefield of compliance challenges. I will say just anecdotally for me, a lot of what I do day in and day out is physician arrangements of all stripes, and the percentage of recruitment arrangements that can go sideways or create issues is higher than the others. And I think that's just because there's a lot of nuance and complicated requirements that we need to think through and meet when we are setting these up. There are multiple regulatory schemes that we need to be aware of. Stark Law is of course a very important one. This is not a Stark Law 101. It sounds like we've got some sophisticated audience members here. But just as a quick recap, when you have a referral source to a hospital and the Stark Law applies, it is strict liability. So you're in or you're out, and you have to technically meet all the requirements and exception. And the recruitment arrangement has a lot of requirements in it. And we also have to think about the anti-kickback statute whenever we're providing remuneration to a referral source. And as Charles mentioned, for those hospitals which are tax-exempt entities, 501c3, we also need to think about private benefit issues and whether a recruitment arrangement is serving a community need or whether there's perhaps something else going on with a private entity. So that's what makes them tricky on a technical side. There are a lot of technical requirements to meet, but I will say that operationally, they can also be complicated because you could have an instance where it just might not work out with a recruited physician. There's this additional unknown of bringing in a recruit that is not a known quantity, and they might not stay in the community. There might be miscommunications or misunderstandings about exactly what this arrangement means. And so for those reasons, we see this as areas where you really need to understand the nuances and be pretty thoughtful in setting these up and in implementing them.
Yeah, just the human dimension, I think, also creates challenges. You have a new doctor who comes into town, and that doctor has colleagues on staff in their specialty. They may want to help, but this is also a competitor. And and if they're joining a practice, they're a colleague, helping hands, but also a competitor. There's issues of fairness and expectations. What is the new recruit thinking when they go into it? What are the existing doctors expecting? And there's a lot of room for mismatches there. And I've seen an awful lot of recruitment arrangements work out, but a fair bit that don't. So.
Okay, so I'm just going to walk through at a high level the basic requirements of the Stark Law exception for physician recruitment arrangements. This is by no means comprehensive. If you were to pull up the exception, it would be 2 full pages of slides in fine print. But this gives you really the kind of fundamental concepts. So when we're talking about recruitment assistance and Stark Law applicability, we are talking about remuneration provided to a physician and or potentially a physician practice, which we'll talk about, which induces the physician to relocate to the hospital's geographic area and become a member of the hospital's medical staff. And all of these have, a lot of meaning to them. And so we're going to get into more detail about what does it mean to relocate? What exactly is the geographic area that we need to be thinking about? Beyond that, as with many Stark exceptions, the arrangement has to be set out in writing. It needs to be signed by the parties, and it cannot be conditioned on the physician's referral of patients to the hospital. And that's one that I want to pause and take a second on and invite Charles to speak a bit, because this seems like a pretty straightforward provision, but we are aware of some challenges, right, to what seems like a pretty innocent arrangement. So Charles, I'll let you take it.
Yeah. This might strike you as almost like a Stark requirement that's like boilerplate, that the arrangement's not conditioned on the physician's referrals of patients to the hospital. But believe it or not, there's actually a couple of federal cases out there where clever whistleblowers have brought False Claims Act cases against hospitals asserting that there were Stark violations based on the fact that the physician recruitment arrangement required the doctor to come in, relocate to the geographic area, join the hospital's medical staff as an active medical staff member, which is, in my experience, pretty much universal in these arrangements. But as you know, to be an active medical staff member in a lot of hospitals requires at least like 10 patient admissions or 10 cases performed in the hospital, so that the hospital has an opportunity to judge the quality of that physician's work and consider them an active member in good standing. And so the whistleblower said, well, if you require them to be an active member of the medical staff, and that requires at least 10 admissions or referrals in a year, then you're conditioning the physician recruitment on their referrals to the hospital. And fortunately, both federal cases, the judge didn't buy that and said, no, requiring them to become a member and that the minimum number of admissions to become an active member is simply about quality of care and monitoring that. It's a medical staff membership requirement. It's not conditioning remuneration on referrals. But that's, again, just a note of caution out there. No good deed goes unpunished, I suppose.
And to wrap up the list, I would also consider the next one is what you might consider stark boilerplate, but the remuneration cannot be determined in a manner that takes into account the volume or value of referrals or other business generated. And lastly, the physician is allowed to establish staff privileges elsewhere at other hospitals and refer business elsewhere. And I'll say, this is a clear requirement. It's definitely in every recruitment agreement that you will see. Again, with the human element, I have seen, there's some feeling when you put the work into bringing your position to the community to feel a bit proprietary, that this is your position. And I think it's important to underscore that that's not the case, that this position might well go elsewhere, refer elsewhere, and that's just part of the package that you're signing on to. Okay, so to get more into the weeds, what is the geographic area served by the hospital when we were thinking about physician relocation? So it's the area composed of the lowest number of contiguous zip codes from which the hospital draws at least 75% of its inpatients. Very data driven based on patient admissions. One quick thing from a legal perspective, but then I definitely want to hear from Charles and Tynan, who I'm sure you're running these calculations and thinking this through with clients all the time. But one area of flexibility here that Charles and I found is that there's not one service area necessarily. It's not always the same and only answer. It really depends how the zip codes work. You can pull up a map and really look at where the admission's coming from. And so you might have some options to pick and choose from when you're trying to figure out whether the physician is relocating, which can be helpful for us and can be a nice surprise or a little bit counterintuitive to someone who's not doing this regularly. But Charles, Tynan, please weigh in on this one.
Yeah, so depending on your geographic service area, I've seen hospitals where, you get like the 10th zip code gets you to 75% of your inpatient admissions, but you could pick either of like 2 zip codes to get to be the 10th. So you have non-contiguous zip codes that get you to say 74%, but then you can pick from one there or one over there to get your 10th zip code. And that can, and CMS actually said, either of those works. In fact, you could use both. You could drop one doctor in this one and one doctor in that one, depending on their specialty, and that both would count because they're both the minimum number of zip codes contiguous to get to 75% of discharges. So.
Yeah, and this is where I like that we have that flexibility, even though sometimes it takes a little finagling to get there. But it can be really telling. I think the other thing here too that's important that the regulation is very clear on the one thing is it's different, can be different from your strategic service area. So you might have a primary and secondary strategic service area as a hospital. You can't necessarily use that to meet this definition. You have to really go through the exercise of ensuring that you're meeting this definition, which unfortunately, to a degree, is somewhat antiquated in that it requires the definition of that service area by inpatients. you know, Amy, Charles, that's probably a conversation for another day, but you know, that it's the cards were dealt and the hands were dealt. And so the nice thing is we do have that flexibility that Charles and Amy discussed. So it's a little bit of a bright light, but we'll come back to the inpatients at a later time.
Yeah. So the other topic on this slide is what does it mean to relocate? Because the remuneration does need to be to induce that physician to relocate. There are some exceptions listed towards the bottom, you know, for a new physician that doesn't really have a practice yet, you know, 1 year of practice or less, or coming out of certain government agencies. But most typically, we are assessing whether this physician is relocating to the service area and whether the remuneration is necessary for them to induce them to do so. And so what this means is they're relocating over 25 miles, or their new practice derives at least 75% of its revenues essentially from new patients compared to their old practice. You know, one thing I've seen, which I think is important to mention, is it really is important to do a little pressure testing and make sure this is really necessary for the physician to relocate. Sometimes it is, sometimes it might not be. You know, are they weighing other offers in other areas? Are they from this area and went to medical school in this area and, you know, did a residency elsewhere for a couple of years, but they're coming back anyway? Just, it's a very factually intensive question in my mind, which is important just to do a bit of pressure testing on. We are aware of at least one DOJ enforcement action from the past couple of years with an East Coast system where the physicians, it ended up, were not relocating. And so that was an issue for them under a False Claims Act allegation. Tynan and Charles, anything you want to weigh in on the relocation aspect of this?
Yeah, I mean, the whole concept of relocation is that the community has a shortage of a particular specialty. And if you're, you know, quote unquote, recruiting somebody from across the street, you're not really doing anything to add a doctor of a specialty, you know, to the community. You just moved somebody, you know, from one block across the street or something. That's not what they're looking for. So, yeah, I'm sometimes reminded that, you know, this is, you got to focus on this. My very first stark self-disclosure to CMS over a decade ago was a hospital that recruited a physician basically from across the street, and that didn't satisfy the Stark exception, and so we ended up self-disclosing that one.
All right, so just briefly, I thought we would touch on when a physician is being recruited and joining an existing practice in the community, because this is a very common scenario as opposed to a physician relocating and setting up their own solo private practice. So there are a few key requirements to point out. We typically see these as three-party agreements where the physician recruit is signing as well as the physician practice. And that's because there's often an income guarantee component to these recruitment arrangements where essentially what the hospital is doing is looking at, well, how much revenue is the physician bringing in attributable to that physician, and what are the expenses to bring on that physician. And if there's a shortfall, that's where we'll see some income guarantee. And so because of that, there might be some remuneration also to the physician practice because they are bearing some expense, right, of bringing on this physician. They might also be paying some recruitment upfront costs, you know, moving the physician over, you know, looking at student loans, and there's often various parts of the package. So it's possible that the physician practice might also receive a financial benefit. And in that case, there's more layers to the agreement. The other important piece to mention here, which I know Tynan will have a lot to say about as well as Charles, is whenever we have these arrangements with the physician practice as well, and we're looking at cost allocation to figure out, you know, what is the remuneration that should be paid over, it's really important to focus on the actual additional incremental costs that are attributable to the physician. I mean, I'll throw out one easy example because I think some are not as easy, but one is, you know, what is the physician practice paying for the office space? What's its rental amount? And is it changing its footprint at all to bring this new physician? If not, that's a fixed expense. There's no incremental additional cost because you brought in a new physician. Again, I took the softball one, but this can be a very, very nuanced topic and a complicated one. So Charles, Tynan, anything you want to talk about on joining an existing practice?
Yeah, I mean, this is the point of this is really the government's intention that the practice that the recruit is joining not sort of experience a big windfall as a result of the recruitment. And back in the old days, kind of pre-Stark, the practice would want to basically just do an allocation of overhead. So if it was a 3-doctor practice and they were adding a 4th doc, they would just want to allocate 25% of their overhead as an expense to the new doctor. And this is designed to prevent that and say, no, we're just going to look at the additional incremental cost of the new doctor. Existing overhead is not going to be allocated to the new doc.
So it's a discipline, I think, that the practice that's accepting the physician and the income guarantee has to get in. So it's sort of the get your house in order before you do the recruitment, and really understand this is going to go a long way in preventing some heartache in the future. So it's the discipline of understanding that cost allocation that I think is just good basic practice, best practice going into it.
Yeah, and I know we have it at the end. We have some compliance tips, but one thing I've seen is really coming up with a spreadsheet that everyone agrees on in advance. Really being very detailed on the front end to avoid disputes on the back end. Charles, I'm going to hand it over to you to talk about anti-kickback statute.
Okay. Yeah, as Amy mentioned in the beginning, the way the Stark law works is it's essentially a strict liability statute. That is to say, unless your financial relationship satisfies the exception, the physician recruitment exception, the physicians on the other side of it are going to be prohibited from referring Medicare patients to the hospital. So you really have to meet the exception. Under kickback statute, because it's intent-based, it prohibits, kind of intentionally remunerating somebody to induce their referrals. There are safe harbors which will protect you from the kickback statute if you meet them, but they're not mandatory. So you don't have to be in a safe harbor under the kickback statute. If you're outside the safe harbor, you're not automatically illegal. You're simply evaluated based on fact and circumstances. And as it turns out, the OIG has seen fit to draw the safe harbor for physician recruitment very narrowly. And frankly, I rarely can think of a time when I've been able to get an arrangement into the safe harbor. It's really just for physicians being recruited into a health professional shortage area, or HPSA, which is a defined term that doesn't cover that much of the geography in the country, frankly. And benefits have to be limited to 3 years. There's a bunch of little requirements, and then at least 75% of the revenues of the newly recruited physician have to be generated from patients residing in the HPSA or a medically underserved area or a medically underserved population. These are all pretty narrowly defined subsets of most of the United States. So most of the recruitment arrangements, as I said, don't satisfy the federal safe harbor. One tricky thing is this benefits of no more than 3 years. I initially had assumed that meant that, like, for example, an income guarantee couldn't go for longer than 3 years. But I've understood in informal conversations with the OIG that they view the 3 years as not only the income guarantee on the front end of an arrangement, but also the period after that where the physician, any loan amount is amortized and forgiven if the physician stays and practices in the community. So assuming that that's still true, that was really in an informal telephone conversation I had years ago. But if they are still viewing it that way, I suppose then you're kind of limited to like a 1-year income guarantee and a 2-year amortization forgiveness, which is a common time frame, but I often see them a little bit longer than that as well. So that's all I got on that one.
All right, then let's move on. Just have patience with my technology skills here. Okay, here we go. Just to wrap up this section, I thought we'd talk briefly about some of the common issues or the questions that we get, in addition to the pitfalls we've already discussed. And this is just brainstorming a couple that we wanted to mention. So the first is when you're recruiting into a large, well-funded group. We wanted to mention this one because just like how I was talking about, you might pressure test whether the physician is actually relocating. When you have a well-funded large group, I think it's important to pressure test whether the remuneration is really necessary for the inducement. And it may be, but it really is fact intensive. So if a large group is likely going to bring on this physician anyway, and they have the financial means to do so, that would be a factor weighing against whether this is really necessary to bring on the physician. And so that it's just a factual inquiry. The other thing that can come up when you've got a large, well-funded group is, and it's not clear whether it's reasonably necessary, it's not just a Stark Law issue or a kickback issue, but again, tying back to the tax-exempt questions which we asked, and whether it's giving a private benefit to a private entity as opposed to really necessary to promote a community benefit. Charles, Tynan, I don't know if you want to weigh in on recruiting to large groups.
Yeah, I mean, again, this is a kind of a facts and circumstances. You know, you do want to feel comfortable that the remuneration being provided is necessary to induce the relocation. And you may think a large, well-funded group doesn't really need it. But I don't think they should be disqualified just because they're a large group from ever doing recruitment arrangements. There's no prohibition against recruiting to a group beyond a certain size. I just think it's something to keep in mind. And sometimes, we see frequent flyers, we see hospitals that keep recruiting doctors into the same big group again and again and again. And, you do feel like, if you do too many of these, it may attract attention, may get somebody excited about trying to make the case that you're doing that because they're a favored referral source.
Yeah, I mean, so and Tynan was pointing out when we were just chatting before, a lot of this is about documenting, just document, as she said, and really going through the analysis and the rationale for why. Because, and Charles and I have talked about this as well. In some cases, you can have a lot more comfort when you're working with a larger group that they have the internal infrastructure and the means and the know-how to really, work through the recruitment arrangement, track the costs, and do things appropriately. So it's just something to be aware of, with each recruitment arrangement that you're entering into.
I guess I'll talk quickly about the side-by-side recruiting. This is kind of a novel, I don't know, I've seen this a bunch of times, but it's a little novel. And the idea is, instead of having the recruit come into the community and join an existing practice, instead the physician is recruited and lands side by side with the existing practice. In other words, the physician doesn't join, doesn't become an employee or partner or work for the existing practice, but instead becomes a solo practitioner who enters into maybe a sublease and an expense sharing arrangement with the other practice. What this does, potentially benefiting the existing practice, is that they can now charge the recruited physician fair market value for space and support services, et cetera, which is likely to be an amount more than additional incremental costs had the physician join the practice. Mm-hmm. And therefore, I think these arrangements need to be kept an eye on, though, because you need to make sure that the recruit is truly coming into solo practice and hasn't in fact joined the existing group, which could create all kinds of problems. So you really want to make sure that they're billing, they have their own billing numbers, they're separately enrolled in managed care contracts, they've got their own signage on the door, and they're keeping separate medical records. I mean, you really need to be vigilant to be sure that they're in fact truly a solo practitioner who's just in a space sharing or sublease arrangement. But that is a model I've seen some folks implement. Well, another one is, we talked about this before, when recruits aren't working out. This is one of the trickiest things that you see. It's human nature, the new recruit and the existing practice, sometimes it just doesn't work. It's like a bad marriage and it's coming apart at the seams. And A lot of times, frankly, it does end up in arbitration or litigation, but there are a few situations like this that we've been able to rescue with clients where the recruit's not working out. You have the recruit essentially come out of the arrangement, and a new doctor, a new recruit comes into town and essentially steps in as an assignee of that arrangement and sort of steps into the shoes of the doctor who wasn't working out and who leaves. And I've gotten these things to work to have the new doctor then take over the remainder of that income guarantee arrangement. The old doctor signs a tolling agreement and agrees to remain on the hook in case the successor doesn't work out. But if the successor works out and fulfills the obligations, the original obligations, then they're off the hook, and it sort of ends happily ever after. So I've been able to rescue a couple, but there's also a few that have gone wrong and proven unsolvable.
Yeah, and just to wrap up this slide, and in, well, I won't promise 10, 20 seconds or less, because I want to move on to the next section. Just to keep it on your radar, amending recruitment arrangements is something to proceed with caution about. Not that you can never do it, there may be legitimate reasons to do it, but CMS has said on multiple occasions that there can be issues with amending recruitment arrangements because the remuneration needs to be necessary to induce the physician to relocate. If they've already relocated and then you're amending in a way that might increase the compensation or provide more favorable forgiveness of something that they might otherwise owe, that could be an issue under the Stark law. There might be other perfectly legitimate reasons to amend, but if you get a request to amend, I would say it's another case by case. Just take a pause and think about what's being asked and whether you can do it in a compliant way. With that, I'm going to pass it over to Laura. I think we are at our next polling question.
Thank you. Our second polling question is, how many recruitment arrangements do you anticipate entering into in the next 1 to 3 years? None, 1 to 5, 5 to 10, or more than 10. Remember, you must fill out the polling question in order to receive CPE credit. You will have 30 seconds to answer. Thank you for participating in our poll. Now I'll hand it back over to Tynan.
Thank you, Laura. We've got most participants that are going to be actively entering into arrangements. So lots of good information that Charles and Amy just went through. 5 to 10 seems to be the one where lots of folks landed. So really, really very interesting. Thank you for sharing that feedback, because I think for us, it at least gives us some direction too in terms of the comments that we make. So we're just going to spend a couple minutes here on what are provider needs assessments and how do we determine need. I know one of the things we talked about as a group in preparation for this was, we know lots of organizations do these analyses internally, and so, what are some tips and tricks that we typically use? And candidly, these have evolved pretty significantly since the time I started doing them. But really, when you think about it, the true term provider needs assessment, you may know it historically as a medical staff development plan or a physician needs assessment. We call it a provider needs assessment now because we really do take into consideration the presence of advanced practice providers in a community and in determining that need. But it's really a directional analysis, and what we're trying to do is get at on a per specialty basis, what's the supply, demand, surplus, deficit of that particular specialty in order to support the recruitment that Charles and Amy's just talked about. The one thing I will note is, and we get this fairly often, is we'll have folks call and say they want a community health needs assessment. And so we ask a couple questions, and it turns out that really they're not looking for a community health needs assessment, they're looking for a provider needs assessment. And the nuance there is that the community health needs assessment is required if you're a tax exempt hospital, and it was a requirement that came about through the Affordable Care Act. There are some components of a community health needs assessment that are provider needs related, but it definitely is a more comprehensive analysis for purposes of the IRS, as opposed to not supporting a recruitment, although, as we've talked about, they will go hand in hand. It's also, an important tool that's part of a strategic planning process. But again, you have to be aware of what your reasoning for doing a needs assessment is, because you might make some decisions about how you define that service area differently if you're doing it for strategic purposes versus doing it for recruitment support. So the real key things in doing any needs assessment are understanding the demand for the providers in the community, the supply of the providers in the community, and then taking into consideration some nuances to inform what the surplus and deficit may be. So Amy and I talked about this a little bit in preparation, but there are a number of different approaches that are used to develop, the demand side of the equation. And you can go back and, there's surveys that are still in existence that are, 30 years old that people will rely on. Jiminac is one of them. It really was at one point the gold standard for determining physician to population ratios. And honestly, I think we still see it used sometimes. We have it, we know what it is. It's in our model, but it's a pressure test. We don't rely on it typically. But it is a gold standard and has been around for a long time. One of the other things that we look at the AMA master file. We look at some of the state workforce data that the AAMC publishes. We marry lots of specialty specific physician to population ratios that we get from organizations, professional associations, specialty associations, and then we also, for primary care, are now marrying in panel size, because that's a really good indicator of sort of the quality, the outcome piece of it. So you're trying to marry what's going on from a health perspective in a community with that true sort of physician to population number. The supply piece is honestly one of the more challenging pieces, especially if an organization doesn't have a real handle on the supply of providers in their community. Oftentimes, if it's a hospital, they'll start with their medical staff roster, but then we marry that with other data that we find, and oftentimes we'll find that they're providers in the community that the hospital that's trying to support the recruit has never heard of, and that's because they're in the community and they're maybe serving a non-affiliated urgent care center. And so we have to work very closely with those hospitals to make a decision as to, how do we make some adjustments for those folks that they don't really know as much about from a practice standpoint. So there's sort of this quantitative analysis that we do, which is, compare supply and demand to come up with a surplus or deficit. But, facts and circumstances, back to Charles's point, one of the things that both, the OIG and the RRS have said, that physician to population ratio and surplus deficit is really one factor. There may be many other factors that would support a recruitment in the event you've got a surplus of a particular specialty. And so this is where the art part of this comes into play, is to really thinking through what's behind that recruitment and why is that recruitment important to the community. So a couple of key things. Is there a long wait time for patients to get in to be able to see a certain specialist? You're not going to find that out from the physician to population ratio. You're going to find that out from hearing from patients that it takes them 3 months to get in to see a rheumatologist. Okay, well, that's an indicator right there and a factor that really does have some weight to it. Charles talked about the designation HIPSA, MUA, MUP. Those are recognized governmental definitions, clearly, supporting that there's a shortage. Sort of contrary sometimes to what we see in rural versus metropolitan areas. If it is a metropolitan area that has an area that is underserved because there just aren't physicians practicing there, that's another factor. Reluctance to relocate. We see this, time and time again with hospitals that are trying to get subspecialists to communities that we know are needed, but it takes them 5, 6, 8 years because they're in a rural area and they've got to put a competitive package together. And then, if you're really just unable to obtain or to keep physicians in your community. So a couple other things. Documented need for folks that aren't providing services to Medicare or Medicaid or self-pay patients. And then if there's a minimum number of physicians that's required to provide a service, and sometimes you see this in surgical subspecialties. One that comes to mind is, GYN oncology, for example, where you're typically never just going to recruit one GYN oncologist. You're going to recruit 2 because of coverage and the nature of that specialty. So kind of really getting into why we're doing the recruit. Just a couple of things to touch on from I'll call this the nuance slide, because these are things that come into play when we think about supply. We will make adjustments to the pure supply for age. And I'll say different communities might have different age adjustments. It used to be, I think, when we were doing these 10 years ago, we maybe utilized standard adjustments for age for advanced practice providers. But now we're looking and saying, gosh, we know OBGYNs likely aren't going to practice as long as a primary care provider. A surgeon maybe isn't going to practice as long as a primary care provider. So when we're making age adjustments to that initial supply, we'll often tailor it to what we know is going on in that community and within the specialty. Same thing with the APPs and how they practice with different specialties and geographic location to geographic location, how APPs get utilized. Telemedicine, we had a situation recently where we had this oversupply of neurologists. And it wasn't until we got into the weeds that we realized, well, half of those neurologists were telemedicine. And so to include them as a full-time provider of service in the community was overstating that community's need for neurologists. Academic medicine's another one where we see it, and psychiatrists and behavioral health providers in the community is also where we'll make some adjustments. One of the final things I'll say is that we've really started looking at claims data and in an effort to sort of inform, again, that sort of the outcomes piece of it is if you've got a community where physicians have fewer claims per physician, and you can look and say, okay, what's the diagnosis of those patients that physician's seeing, we might adjust some of our assumptions because of, we know it might be taking a physician to see, they're seeing fewer patients because of more comorbidities. Again, not going to capture that in a pure physician to population ratio. So that brings us to the third polling question.
Thank you. How often does your organization complete a provider needs assessment? Every year, every 2 to 3 years, every 5 years, or whenever we have a recruiting need? Remember, you must fill out the polling question in order to receive CPE credit. You will have 30 seconds to answer. Thank you for participating in our poll. Now I'll hand it back over to Amy and to Charles.
All right, thanks so much. Just advance the slide here.
Amy, one quick thing while you're doing that is I think the results were pretty consistent with what we typically see is, it's usually every 2 to 3 years, even though you might be making a 1 to 5 year kind of projection. Most organizations are doing it every 2 to 3 years, although, there's one of the things I'm a big proponent of is trying to keep it updated if you possibly can, because it's a living, breathing document. It can go, as everybody probably on this call knows, it can go stale really fast, which is why good policies and procedures as to how often you're updating it and when you need a specific kind of refresh on that is key, which I'm hoping we'll touch on here.
Yeah, sure. So it's tough because those of you in the audience don't know, I've been using a lot of our planning sessions to just pick Tynan's brain, and I have a lot of questions on the provider needs assessment, but I will just have to bother her one-on-one outside of the forum. But we thought we'd wrap up, and we just have a couple minutes left. But you know, these are some ideas that we had about key processes to really help mitigate risk and support compliance in these arrangements. I'm going to suggest that maybe we each just pick one, you know, that we really want to touch on that we think we really haven't hit enough yet in this hour before we wrap up. And I could start with just board approval because we haven't touched on that, and that is a key part of the process that I work through with my clients. The IRS has stated, you know, for tax exempt entities that board approval is really a factor that they look for, either the board or a designated committee of the board. They will approve of a recruitment arrangement. And the one thing that I would add to that is when you are thinking through and putting together your board packets, that they are really comprehensive. It is not a rubber stamp. They should really be provided a lot of information about the recruit and about the financials of the arrangement so that they can make an informed decision. And I'll turn it over to you all to share whatever last nuggets of wisdom you can provide before we have to close this out.
I'm going to talk just very quickly about the amount and duration of support. So we've talked a lot about what I've seen is, which is the most common form of physician recruitment arrangement, is the income guarantee. And one of the decision points when structuring an income guarantee arrangement is what to do as the physician, the recruit ramps up and their collections start to increase. And if they're successful relatively early on, there may be a point in that first, even a 1-year income guarantee, where their collections exceed that minimum guarantee amount, and they're now earning, you know, more based on their professional services than that guarantee. A lot of arrangements then call for those extra collections to come back and repay any subsidy that's been provided on the front end, with the idea being that prevents you know, any kind of a windfall, because you loan the money in the first few months as their collections are ramping up in order to support them in that period when their collections were less than they needed to make fair market income. But once they exceed that, you know, the hospital ought to be repaid. So you often see that. Sometimes you see it as a percentage, not 100% of the excess, but maybe 50-50, with the idea being that you want to motivate that doctor to continue to work hard to see patients rather than take all the excess back. But sometimes you don't see that. Sometimes you just see, well, they're successful and they came in. We provided the support for the ramp up period, but now they're off and running, and you know, they can keep the money. So you see different things, but you may want to think about, you know, how you're structuring that and what you're trying to accomplish, and whether or not you're providing a windfall or the right motivations, and that's something to think about.
I think my final one, I'll talk to the evaluate and monitor, because I think that encapsulates a lot of these. And you know, like with anything that's stark anti-kickback related, it's really important to make sure that, to Charles's point, you're going back and reconciling as you need to, and you're monitoring those agreements, you know, sort of real time. I mean, you know, not every week, but that there's some touch point so that you don't get into a position, the sort of the gotcha position unintentionally. I think some of the recent cases that have occurred, you know, had there been some monitoring and evaluation along the way, there likely could have been some, you know, heartburn prevented. It also, I think, on the needs side, makes it easier to update and keep things updated, so you're not reinventing the wheel every 3 years or every 2 years. And so just from a ability to be nimble, I think there's some tips and tricks that we've started looking and employing and helping folks with, to be able to kind of make those decisions a little more quickly and spend their resources where they need to, which is on the recruitment of the physician. So I think that brings us really right up to our top of the hour. And Charles, Amy, I just can't thank you both enough. You've been great to work with on this and lots of great expertise. And I think we could probably do a follow-up session on some of the things we didn't really get into the weeds as much on here, but just wanted to thank you all both very much.
Thank you, Tynan. It's been a pleasure.
Laura,
Yeah,
we'll turn it back over to you.
Thank you. And thanks to our presenters, Amy, Charles, and Tynan. If you have any questions, their presentation and contact information will be emailed to you along with a recording of today's webinar. Also, if PYA can provide assistance with audit, tax, compliance, valuation, or physician services, please call or email us. You may also visit our website at pyapc.com for more details about our specific areas of expertise or to subscribe to receive PYA insights. If Hooper, Lundy, and Bookman PC can help you with health law needs, please visit them at www.health-law.com. Please remember to stay on the line once the webinar disconnects to complete a short survey for CPE credit. On behalf of PYA, thank you for joining us and have a great rest of your day.